Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Our first presenter today is Dan Smith, a PGY2 emergency medicine resident at NewYork-Presbyterian, who will be presenting on timing of initiation and efficacy of dual antiplatelet therapy in minor stroke or high-risk TIA.
Awesome. Thank you so much, Maddie, for the introduction. So we'll go ahead and jump right into it. Before we get into the article, I just wanted to give some brief background that will help us understand this trial more. And so just starting out with a few definitions, acute ischemic stroke is a sudden neurological dysfunction caused by focal brain ischemia, typically lasting more than 24 hours or with evidence of acute infarction on brain imaging. And we usually assess this with the NIH stroke scale, and it quantifies the stroke severity on a scale from 0 to 42, with higher scores indicating more severe neurological deficits. And it evaluates multiple aspects of brain function, including level of consciousness, language, motor skills, sensory perception, vision, and coordination. And the NIH stroke scale is used to help guide treatment decisions such as the eligibility for thrombolytics, and it also helps to predict clinical outcomes. You'll see here I've listed the definition that they've included in this study. So they defined a minor stroke as being an NIH stroke scale score of less than or equal to 5. And we're also going to be talking about TIA today, transient ischemic attack. And this is when arterial blood flow to the brain tissue is temporarily disrupted, causing focal neurological symptoms, but spontaneous restoration results in symptom reduction without permanent tissue injury. And typically this is evaluated using the ABCD score. It's a clinical tool used to estimate the short-term risk of stroke after a TIA based on 5 criteria, which include age, blood pressure, clinical features, duration of symptoms, and history of diabetes. So current guidelines, as we will review here on this slide and the next few slides, they recommend DAPT therapy for patients with minor stroke or high-risk TIA who present within 24 hours, and that's a strong level recommendation based on a few clinical trials that we'll explore in the next coming slides. But as I'm sure many of you are aware, there's many delays that occur within the emergency department when we're triaging these patients, and sometimes our time to treatment can be extended. So maybe for some patients, we're not always going to hit that 24-hour mark. And so the question is whether DAPT beyond the 24 hours can still confer a clinically meaningful benefit. And so here are just the AHA 2026 guideline recommendations written out for you. There's a class 1 recommendation, as I just explained, for those patients with minor stroke, high-risk TIA who are not going to get thrombolytics. They recommend DAPT therapy with aspirin and clopidogrel utilizing the loading dose I have referenced for you on the bottom of this slide. And it's a very strong recommendation when these patients present within 24 hours. And we can compare this with the recommendation on the right, which is a moderate level recommendation. This patient population is slightly different. NIH stroke score of less than or equal to 5, still high risk TIA, but these patients are presenting within 24 to 72 hours from stroke onset, and they have greater than 50% occlusion of that artery as well, also not a candidate for a thrombolysis. In this patient population, there's a moderate recommendation for the initiation of DAPT therapy for 21 days, followed by the single antiplatelet therapy. And they say that it's reasonable to reduce the risk of 90-day risk of recurrent stroke. And this is just a nice visual that they also have in the AHA 2026 stroke guidelines for treatment algorithm that you can utilize for your patients to see where they qualify. If you go down the left side, this is the patients with last known well within the 24 hours, low minor stroke and high-risk TIA. Then you'll see a strong recommendation for DAPT based on the chance and point trials, which we'll discuss next. And if you follow the algorithm to the right, you see the last known well greater than 24 hours, greater than 50% occlusion, last known well within 24 to 72 hours, then we also have a moderate recommendation for DAPT therapy as well. So just going over the landmark trials prior to getting to the trial I'm going to be discussing today is going to be important because we'll see sort of the niche that the authors wanted to find and study. So we have two large randomized controlled trials, the CHANCE and the POINT trial, that established the benefit of early short-term DAPT with clopidogrel plus aspirin over single antiplatelet therapy for minor stroke or high-risk TIA. The CHANCE trial evaluated DAPT with clopidogrel loading dose of 300 milligrams followed by 75 milligrams plus aspirin, dosed at 75 milligrams for 21 days, followed by clopidogrel alone, and this was versus just aspirin alone. And these patients presented with within 24 hours of stroke onset, and DAPT was associated with a decreased rate of recurrent stroke at 90 days over aspirin, but there was also an identical rate of moderate severe hemorrhage in both groups. So that's important to note. In a post hoc analysis of CHANCE, DAPT was associated with an improved 90-day functional outcome as well when compared to aspirin alone. And then when we look at the POINT trial, it replicated a lot of the benefits that we saw from the CHANCE trial in regards to DAPT therapy. They also looked at clopidogrel plus aspirin, but this was also an international population. And in contrast to the CHANCE trial, they initiated DAPT earlier within 12 hours symptom onset. And they also utilized a higher loading dose of clopidogrel as well, 600 milligrams. They had a longer duration of DAPT therapy, and they also had variable doses of aspirin. But as far as the composite endpoint of being recurrent ischemic stroke, myocardial infarction, or death at 90 days, DAPT resulted in fewer ischemic events, but also more hemorrhages, just like we saw in CHANCE. And unlike the CHANCE, they didn't see an improved 90-day functional outcome with DAPT. They saw no difference. So then moving quickly on to Thales trial, this was patients with, again, moderate stroke or high-risk TIA. They presented within 24 hours of symptom onset to DAPT. This time we're using ticagrelor plus aspirin versus just aspirin alone. The ticagrelor loading dose was 180 milligrams followed by 90 twice daily. And the aspirin regimen was higher, like 300 to 325 on the first day, followed by 75 to 100 daily. DAPT with ticagrelor plus aspirin was associated with a decrease in the primary outcome of stroke and death at 30 days, but was also had an increased risk of bleeding. And lastly, just to touch on the INSPIRES trial, this was conducted in Chinese patients with identified occlusion greater than 50% in the minor stroke or high-risk TIA. These patients, this is a study that established the range between the 24 to 72 hours after symptom onset. And these patients were randomized to DAPT with clopidogrel aspirin for 21 days, followed by just clopidogrel versus the aspirin group alone. And the loading dose of clopidogrel was about 300 milligrams and aspirin was 100 to 300. And DAPT therapy initiated within 72 hours of stroke onset was associated with a lower risk of recurrent stroke at 90 days than compared to aspirin alone, but was also associated with a higher risk of bleeding. So based on these trials is where our AHA recommendations come from. Strong recommendation to initiate DAPT within the first 24 hours. And then we have a moderate recommendation for those patients in the realm of 24 to 72 hours based on greater than 50% occlusion. And again, minor stroke symptoms, high-risk TIA. So moving on to the trial we'll be looking at today, the objective was to assess the relationship between the time of DAPT initiation and the composite outcome of stroke recurrence, MI, and death within 90 days for patients with the minor ischemic stroke or high-risk TIA. And this was a prospective observational registry study involving 20 stroke centers across South Korea. So between January 1st, 2011 and April 30th, 2023, the authors identified 99,783 total patients with stroke or TIA. And ultimately, they included 41,530 patients in their analysis that met their inclusion criteria that included greater than or equal to 18 years old, acute minor stroke or high-risk TIA, symptom onset within 7 days before admission, and receipt of aspirin or clopidogrel on admission. And I've also listed the exclusion criteria and excluded patients here for your reference. So a total of 25,112 patients received DAPT and 16,418 received MAPT or mono antiplatelet therapy on admission. The antiplatelet dosing and loading protocols were not standardized in this registry. However, most of the participating hospitals or centers were academic medical centers that followed guideline-based practice and used the usual practice of doing the loading dose of antiplatelets on initiation. And so these patients were randomized not only by mono antiplatelet therapy with aspirin or clopidogrel to DAT by combining both agents, but we'll see that the authors also created different time intervals as far as the administration of these agents. So the outcomes were prospectively captured during hospitalization and through structured telephone interviews and outpatient follow-ups, and events that occurred before hospital arrival were not captured and were left censored according to the study design. Our primary outcome, as I mentioned, is the composite of stroke reoccurrence, MI, and all-cause mortality within 90 days. Stroke reoccurrence in this study was defined as worsening neurological status due to progressive ischemia, swelling of infarcted tissue, or pre-lesional edema following up imaging. And the secondary analysis was individual occurrences of recurrent stroke and all-cause mortality. So this was a large real-world observational cohort and not a randomized trial. So the analytical strategy was designed to approximate a causal inference while addressing many confounding factors and time-related bias. The authors categorized time from symptom onset to hospital arrival into clinically meaningful windows, so 0 to 24 hours, 24 to 72 hours, and then 72 hours and beyond. And they used a single unified propensity score model instead of building separate models for each group. And this approach improved comparability and reduced overfitting. And the treatment effects were evaluated using 3 parallel frameworks: the multivariable Cox regression, an inverse probability of treatment weighting, and a propensity score matching as the sensitivity analysis. The authors also modeled time as a continuous variable with a treatment time interaction, and this allowed them to estimate when DAPT benefit disappeared rather than relying on arbitrary cutoffs. And so they were ultimately able to identify a threshold around 42 hours and validate it using bootstrap resampling to ensure the robustness of the data. So here I'm listing the baseline characteristics. I wasn't able to include all the patient-specific factors on this slide, but we're looking at baseline characteristics of the DAPT group versus the mono antiplatelet therapy across the whole time window, and then specifically within 24 hours. And this was the time to treatment, and they defined it in the study as the interval from symptom onset to hospital arrival. It's important to note that the DAPT group had more vascular risk factors than those treated with the monotherapy, as the DAPT group was slightly older, had a higher frequency of previous stroke, also had a higher history of coronary artery disease, and also prior aspirin use. So getting into some of the results on this slide, we're looking at the cumulative incidence of the primary outcome graphed on the y-axis and time to event recorded in days on the x-axis across 3 different time intervals. So again, 0 to 24, 24 to 72, and then greater than 72 hours. The yellow line corresponds to MAPT therapy, mono antiplatelet therapy, and the blue line corresponds to DAPT. So when evaluating DAPT versus MAPT without respect of timing of treatment, the authors found that the rates of the primary outcome, which was stroke reoccurrence, MI, and mortality at 90 days, were slightly lower in the DAPT group at about 10.7% versus 11.6%. Recurrent stroke occurred in 10% of the patients who received DAPT compared to 11% of the patients that received the mono antiplatelet therapy. And all-cause mortality by 90 days was low and similar between both groups, 1.4% in DAPT versus 1.44% in MAPT. And that's looking at the section A on the slide there. And moving over to section B, when DAPT was initiated within 24 hours, this was associated with significantly lower 90-day event rates compared with the monotherapy, 11.9% in DAPT versus 14.5% in the monotherapy. And this was primarily due to reduced stroke reoccurrence where it was 11.3% in the DAPT group versus 14% in the monotherapy group. There was also a slight reduction in mortality, 1.3% versus 1.6%. Now, looking at section C, when DAPT was initiated 24 to 72 hours, event rates were comparable between groups. Primary outcome, it was about 9.5% in the DAPT group versus 8.3% in the monotherapy group. Recurrent stroke rates were also similar, 8.6 versus 7.5, and mortality 1.5 versus 1.4%. And the adjusted hazard ratio showed no significant difference between all models when evaluating this time frame. Then moving on to when DAPT was given after 72 hours, DAPT was associated with a higher event rate than the monotherapy group. The primary outcome occurred in 7.2% of patients versus just 5.6% in the monotherapy. Stroke reoccurrence was also higher, 6.3% versus 5.1%. Mortality was also greater, 1.7% versus 1.1%. And the hazard ratios indicated a potential excess risk with the DAPT therapy, a hazard ratio of 1.25 when evaluating the inverse probability of treatment weighting. And they had similar trends in the multivariable analysis and propensity score matching models as well. So moving on, here is a similar graph to the previous slide, but this time we're looking at the hazard ratios, which is plotted on the y-axis, and the symptom onset to arrival is plotted on the x-axis. And again, this is our time to treatment. So in this time to treatment analysis, the authors estimated the threshold beyond which DAPT would no longer confer a statistically significant benefit when compared to monotherapy. And the estimated thresholds were about 42 hours for the primary outcome, 45 hours for stroke reoccurrence, and 17 hours for all-cause mortality. And so the authors also conducted a post-hoc analysis to see if the location of the occlusion played a role. Again, we have the hazard ratios on the y-axis, symptom onset to arrival on the x-axis, and the estimated thresholds for DAPT benefit were about 41 hours for the large artery atherosclerosis, 16 hours for small vessel occlusion, and 39 hours for small vessel occlusion. And here, the thresholds were also shorter for among patients without symptomatic steno-occlusion. So that's basically just characterized by the presence of stenosis or occlusion in the cerebral artery. It was 37 hours versus 44, and those with antiplatelet use was 37 hours versus 41 hours. So the authors concluded that initiating DAPT therapy within 21 hours after minor stroke or high-risk TIA conferred clinically significant benefit, and this is consistent with the findings that we saw from chance point trials and Dow's trials as well. They also thought there could be a potential benefit up to 42 hours, potentially offering an extended window for patients that are unable to get treatment within 24 hours. But they also agree that prospective studies are warranted to validate these observations that they've made in their studies. So we need more robust data to really establish the optimal timing of DAPT initiation. There are some strengths and limitations I just quickly wanted to review. This was a large multi-center cohort. They had over 41,000 patients. This was, real world data where the authors were able to observe these patients that come into the ED as far as really extrapolating when the patient's timing of DAPT therapy was being initiated. They also used strong statistical adjustments to account for any compounding variables. And they also did the time-dependent analysis, which was really beneficial in seeing, which time windows were optimal, and then even being able to come up with a cutoff for when DAPT was actually the most beneficial across that hazard ratio. The limitations include that this was an observational study. We also didn't have any safety outcome data, as we saw in a lot of the previous trials, chance point trials. There was increased risk of bleeding, so we didn't have any bleeding outcomes. There was also treatment variability. The dosing was not standardized across these institutions. And then we have limited generalizability because this study took place in Korea only. So my conclusions are that DAPT initiated within 24 hours definitely confers a statistically significant clinical benefit. in regards specifically to reduction of stroke, MI, and mortality. This trial suggests that there could be an extended window up to 42 hours for patients that are unable to be treated within those first 24 hours, but I think more data is likely needed. That initiation within the 48 to 72 hours since the onset may reduce the risk of recurrent stroke, and that's in conjunction with the INSPIRES trials we just seen. And then from this trial, we also saw that starting DAPT after 72 hours may be associated with higher risk of adverse outcomes. So in those patients, I'm likely going to only recommend utilizing the single antiplatelet therapy. And with that, I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.